Virgilio, nice to have you here. Thank you a lot for coming to our meeting. It was really an honor for us to receive you. And I was wondering how are you liking Rio? What are you thinking?
Oh, I love Rio. Thank you so much, Haroldo, for inviting me. This has been an amazing experience, and Brazil is as pretty as everybody said. So thank you.
Okay. Is it your first time here?
It's my first time. I've been to almost every country in South America, never in Brazil.
Your lecture was very, very good for us because you were talking about some technology that we don't have still here in Brazil. I think soon we'll have it. We have the Brain Lab or Globus. Maybe they are coming with the robot here. And I would like to know, how was this change in your professional practice when you changed for a standard surgery and with robotic surgery?
Yeah, I think indeed that Brazil is very likely going to be the first one to get one of those robots. I've been to many countries in South America talking about this, and I do think Brazil is going to soon be there. I think that it's difficult. Change is difficult, and especially the older surgeons are old dogs don't learn new tricks, and they don't like the change because if they've done it the same way forever, why do it different now? The same thing with endoscopic. I'm sure most of the new endoscopic surgeons are younger guys, not so many of the older guys. It's changed in many ways. Number one, as I mentioned, radiation exposure. That's a huge thing that we physicians never protect ourselves from, and radiation is very dangerous. The second thing that I didn't talk in that talk today is the physical and mental burden. And when you do cases, big cases, revisions, deformities, where you're just freehanding the screws or navigation with your hands, at the end of the day, you're tired, physical and mentally. Your shoulders are tired, your arms are tired. You feel like you really need a break. You need a drink. When you do these cases with robotics and you start doing over and over, you realize how calm, how relaxed you are because you feel everything is under control. It's reproducible. So it's changed quite a bit mentally and physically in my cases and myself.
And do you have residents in your hospital?
Yeah, so I have orthopedic residents. I have first year and third year residents. They both rotate with me for their spine rotation. So I always have residents, yeah.
So they start their practice with robotic surgery?
Yes and no. So because I always feel that it's not a dangerous thing, but it's not ideal for them just to learn that. Yeah. So when we do the open cases, on minimal invasive, yes, they go straight to putting screws. When it's open cases, I always have them show me where's the entry point, where would they put the screw, and then we compare with the robotics and so on. The learning curve is very small. So there was a study from Dr. Wang in Miami a long time ago, and he looked at robotic screws between a senior surgeon, a senior resident, and an intern, a first year. And after 25 cases, the accuracy is about the same. So it's reproducible, it's safe. Of course, it's just a tool. You still need a smart surgeon to be operating it. And there's always gonna be pushback from surgeons, like they gotta learn but today, I can assure you, even in Brazil, most of the appendectomies are done laparoscopic.
Yes.
When I was in general surgery 20 years ago, they would say, no, you got to learn how to do an open appendectomy. Nobody will talk that way anymore. It's normal resistance, but it will change.
Yeah, I see this with endoscopy surgery. The old surgeons, they do like a microdiscectomy or very good the way they are doing. But and they have this difficult to learn endoscopy because of that. And the young people, young doctors, they learn much easier than my residents get out the residence knowing how to do endoscopy surgery.
Yeah.
But they have to do open better. They have to be a very good doctor in open surgery to do endoscopy very well.
Yeah.
And how many cases do you think this? You get to have a learning curve?
The number most people use is about 25. 25 cases you're pretty comfortable with. So.
Okay. And the first case, how long do you take? Do you remember?
The first case I decided, we're always smart and we choose a big challenge for our first something. So it was a big person, very big. And I was going to do a lateral D-leaf, and then I was going to put percutaneous screws, just percutaneous screws, 4 of them. I think that took me like 2 hours to put those 4 screws. I was scared. I didn't know what to look for. Now I can put 4 screws in an MIS T-leaf in about 9-8 minutes.
And you do robotic surgery for any kind of surgery you do now, like MIST leaf, O leaves.
Yeah, all of those things I use robotics for.
Fracture.
Cervical, I don't fractures. Even there's a whole talk we give sometimes about unstable spine. When there's high disconnection of the spine, there's tricks of how to use robotics there. But yeah, I use it for everything except for cervical spine, osteotomies, everything.
Do you think that does it have a limit? Robotic?
I think it does. I mean, again, it's a tool, and every robotic system is different. Some of them have limits in one area, the other one doesn't. None of them is perfect. But this is the first generation. We're still seeing the first generation. Like when we look at iPhones, we're iPhone 12, 13. When we look at iPhone 1 and we see at this one now, we're like, wow. Yeah. The same thing is going to happen with robotics.
And when I see the picture of your operate room, I was impressed how big it was, and the whole technology, a lot of devices there. Yeah. And one device that I really use, I really want to try, is the exoscope. I think it's got much easier, and you can look in the screen. You don't put your neck down. And
it's extremely ergonomic. It's still fairly new. We just have two in my hospital. One of my partners uses it for anterior cervicals, for everything. I'm not there yet, but when you're doing L5S1, that you're in an angle, if you're doing posterior approaches, and you don't have to tilt the bed, you just put the thing in whatever angle, and you're very ergonomic looking, especially for training hospitals, because when you're doing anterior approaches, minimal invasive, a lateral D-leaf to the spine, is a very small incision.
Yes.
And I remember in residency, my attending will be describing what he was doing, and then he will let me take a peek, and then he'll keep working. Yeah. And I was trying to guess what he did between every peek that I took. Now I put the camera there, everybody is seeing what's happening at the same time. The scrub tech knows if I got a durotomy, they know what tool I need. It's incredible.
And do you use it like for a microdiscectomy as well?
Yeah. Oh yeah, micro disc, everything. Yeah, for the tube. When I work through a 14, 16 millimeter tube,
so
it's
you
the
work,
best.
You work looking to the mirror.
Yeah, I have a TV that is 80-inch TV. It has depth perception, so it's a 4K 3D TV. I have some special goggles, and I have a 16 millimeter MIS tube, and I put the camera out there, and I'm just working off the TV like this.
Do you know how much is it? The cost?
Yeah, because we just bought one, so it's between 200 to 250,000 each one of those.
And how many cases do you do there for in a year?
Last year I did about 470 spines, so I do somewhere between 450 to 500 a year spines. Yeah.
400 cases per year, just you?
Just me, yeah. Yeah, the last time that I was under 400 was about 4 or 5 years ago. Yeah. Ever since, I'm always over 400 spines, just me alone.
Here in Rio, we do 300 a year, but the entire service.
Oh no,
entire department.
No, that's just me. 470 a year with one room. They don't give me a flip room, so I don't get 2 hours. I get one. So I gotta move fast and do the next one.
How many cases per day?
So per day, the most that I've done is 6, but mostly I have 4 per day.
Okay. So
when it's a big scoliosis, it will be 2 in that day.
Okay. Do you do deformity surgery? Pediatric?
Oh yeah, quite a bit.
Pediatrics deformity?
No, pediatric.
No.
We have a pediatric team that is separate.
And you are neurosurgeon or orthopedic?
Neurosurgeon.
Neurosurgeon.
Yeah.
And you did your residence and.
So I did medical school in Venezuela. So I was born and raised in Venezuela, in Caracas. Did medical school in Venezuela, Universidad Central de Venezuela. And from there, I was going to be a general surgeon. So I moved to the United States and started general surgery residency. I did 2 years. And my plan was always to go back to Venezuela. But that's when Chavez came to power and things changed quite a bit. So I decided not to go back. And then when I was in second year of general surgery, I rotated in neurosurgery. We covered the neurosurgeon, and I was fascinated by it. So then I switched and I went to the Cleveland Clinic in Ohio, and I did all my residency there. Benzel, yeah, Benzel is my chairman, yeah. Yeah, he signed my diploma, so he was my chairman, Benzel, and then I did a fellowship in the Cleveland Clinic in complex spine.
And then you're now in Orlando?
Orlando, yep.
Orlando Health Institute.
It's Orlando Regional Medical Center, so it's called Orlando Health, and then they have about 12 hospitals now, and the main hospital is the one in downtown, that's where I am, Orlando Regional.
Okay. Oh, okay. Thank you very much for your presence here. We really appreciate it, and I hope you can come again in a bigger meeting.
Absolutely. Thank you so
Okay.
much for inviting me. I love it.
Okay, thank you.
Thanks.
What's that?